My Italian is exhausted. Thank you, Benedetto, and thanks to Suk and Caritas for inviting me to join this important and timely discourse, really important discourse. I've worked for over 30 years in both some of the most urban and remote settings in Australia. I'm struck by some of the similarities. So urban marginality mirrors remote, Indigenous and global marginality of people with mental illness. And this is a sample of some of the Australian experience. Urban marginality, just to explore that a bit. While urban homeless individuals with mental illnesses appear to be in totally different settings to individuals with mental illnesses in remote outback settings, there are some remarkable similarities in the challenges they face. Urban compared with remote marginalised people with mental illness, these factors include the multiple complexity factors, and we'll come back to complexity, of mental illness, alcohol and other substance disorder, physical illness, poverty and associated deprivations, e.g. the lack of purposeful role, unemployment, forensic and or trauma history, isolation and dislocation from families, stigma and discrimination. Now, Indigenous people in both settings face additional obstacles to adequate care and to establishing and sustaining stable lives as full citizens in the wider community. In Australia, we have Indigenous people who have lived there for between 40 and 60,000 years. In our neighbouring country, New Zealand, there are also very prominent Indigenous people, the Maori people. How can we optimise the quality of care and the human rights of individuals with mental disorders in these tough circumstances? Now, I don't know if any of you are old enough to recognise this American comic. Why I brought Little Abner and Al Cap into this is they produce some important slang terms which have become international, at least in the English language, so I'm not sure how much you'll recognise this. In an era well before political correctness entered the vocabulary, dog patch, which is where Little Abner lived, exceeded every stereotype of the Appalachian mountain people in USA. The hillbillies in Little Abner's town were poorer than poor. No one had work and the houses were hopelessly run down and ramshackle. So it sounds very much like the social deprivation indices that we're going to be dealing with. Now, one of the things he brought into the visual language was this guy called Joe Blrix, I can't even pronounce it. He was the world's most loving friend and the worst jinx or curse who always travels with a dark cloud over his head. And this, I think, is a great model for depression. If you ask people if they travel with a dark cloud over their head. But I want to use another term that came from Little Abner, and that is, some of you may recognise it, it's called the double whammy. A whammy, in this slang term, was originally an evil influence or a curse. And it was first published as a term in 1939, and then a character called Evil Eye Flegel in Little Abner began to curse people with extra powerful double whammies in 1951. Well, I'm going to introduce you to the quintuple whammy. Now, I know what quintuple means because I've had a quintuple bypass of my heart. So I know what quintuple means. And I had, it occurred to me that quintuple was described, a quintuple whammy described the complexity factors if you are Indigenous living in remote or urban communities with mental illness. And there are these 5 little clusters that occur in this quintuple whammy. First of all, living with multiple deprivations, that is things like homelessness or unemployment. Number 2, isolation or having a history of trauma, particularly in childhood, but any traumatised history contributes. Thirdly, a severe mental illness. And fourthly, any alcohol, tobacco, or substance abuse disorder. And the fifth thing that is common in this complex is physical comorbidity with diabetes or cardiac or respiratory, or particularly in urban settings, HIV and other disorders, and particularly with the young. Now, in terms of complexity, I also want to introduce you to Donald Schon's statement. If you don't know this from the reflective practitioner, it is worth knowing about. And this is about how the high ground overlooks the swamp. And while you look at that, I'll read you his description. He says, this is Donald Schon, if the varied topography of in the varied topography of professional practice, there is a high, hard ground overlooking a swamp. On the high ground, manageable problems lend themselves to solution through the application of research-based theory and technique. In the swampy lowlands, messy, confusing problems defy technical solution. The irony of this situation is that the problems of the high ground tend to be relatively unimportant to individuals or society at large, however great their technical interest may be, while in the swamp lie the real problems of greatest human concern. The practitioner must choose. Shall he remain on the high ground where he can solve relatively unimportant problems according to prevailing standards of rigour, or shall he descend to the swamp of important problems and non-rigorous inquiry? Let me suggest that although we all believe in scientific rigour, I think most of the time we spend working in the swamp and working by choice in the swamp. The most marginalised people with mental illness have similar characteristics, and I haven't filled them all in. But that would include urban homeless and people with severe mental illness, urban young people, urban Indigenous people, asylum seekers, particularly in detention, as we have a lot of detention centres associated with Australia, both onshore and offshore, remote dwellers with severe mental illness, and Indigenous people in remote settings with severe mental illness. On top of seeing those similar five clusters, there is increased vulnerability of marginalised individuals with mental illness. First of all, to punitive loss of housing or punitive loss of benefits. More than 66% of the people who are denied benefits are mentally ill in Australia. Loss of employment rather than understanding of limitations by the employer or by people who are supposed to be supporting these people because they don't understand their poor cognitive and organisational skills and their need for additional support. They're also vulnerable to stigma, teasing, bullying, violence and trauma. They're also vulnerable to problems with the police, the law, criminal justice system, to emotional isolation and suicide, and particularly men who express themselves emotionally less. They're vulnerable to lack access to medical and specialist psychiatric treatment and to a shortened lifespan. There are studies of this showing how social disadvantage, mental illness and predictors of legal involvement go together. And I won't stay on this too long, except to say that the legal involvement includes arrests or nights in jail, convictions, and legal trouble associated with involuntary orders. It's not predicted by the severity of psychiatric condition, but it is predicted by unstable housing, drug and alcohol abuse, lack of education and employment, and being on social welfare. Here's another study which also shows the characteristics of persons who are homeless for the first time or for many times. Just point out the stuff in yellow there, that childhood abuse was common in both groups, and that lifetime substance abuse and chronic physical problems are associated with being homelessness on an ongoing basis. The other connection with this work is Graham Thornycroft's work and the large group of 70 experts that he has got together to form the WHO Global Mental Health Treatment Gap Guide, with a lot of help from Benedetto and other people here. And the conclusion there is globally 20 to 25% of population in any country has a treatable mental illness, and that in developing countries, they only 1 or 2% get any psychiatric care. Worldwide, the average is less than 10% get any psychiatric care, and even in the most developed countries, the studies show that 33% get psychiatric care, two-thirds don't get any care. Of the people who get psychiatric care, sometimes up to half don't have a psychiatric diagnosis or condition, so that means there's another 16.5% who are not getting care. And of those who do get care, often they don't get past primary care, often don't get to specialist psychiatric care. I'm going to talk about briefly a study we did in a very remote context of remote Aboriginal communities where there has been a 10-year drought followed by recent floods that you may have heard about because they were catastrophic. But on the east side of Australia, it is drying out. It's warming up and drying out. And on the west side, the top west corner of Australia, it is becoming much wetter. That's the green part up there. So it's not that we're losing rainfall, but it's shifting. And it's drying out some of the most populated areas of Australia, both urban and remote. After 10 years of drought, we did this study, and we had statements from Aboriginal communities, because we went to most of the Aboriginal communities in the state of New South Wales. And we had statements like Bonnie Johnson, who said, if the river and land is sick, we're sick. If the river dries up, so where will we meet? If the river dries up, so will we. And some of the clusters of information that they gathered together, and we're now looking at that demographically, is that they talked about the decreased employment, less full-time work, because the pastoralists would get these exceptional circumstances payments to tide them over the drought, but the workers wouldn't. The people who worked on the land for the pastoralists, for the farmers, did not get any grants, so they lost their jobs. And there was decreased ability to provide food and fuel for family and cultural events and presents for the kids at Christmas time, etc. Then there's issues of loss and grief and violence. As the loss and degradation of the country deepens, the transgenerational loss of identity, respect and sense of loss, grief and guilt increases. And that was associated for them in an increase in self-harm, intentional injury, suicide, drug and alcohol abuse, and domestic violence. There was also an increase in criminal and other antisocial behaviour, stealing and assaults, and they had this thing called poison cousins, where the gossip went sour and they started losing relationships because of vicious gossip, whereas there'd usually been a lot of solidarity. There was also a skewing of the population profile. The people of working age moved to the regional centres for work, and that left more older people looking after the young kids. And the grandparents were left behind to care for the young, and the Aboriginal population was already getting younger because of decreased life expectancy. There's a 17-year gap in life expectancy between the wider Australian community and the Aboriginal community. So we're now just looking at some solutions, and the solutions we'll look at the cultural level. First of all, we'll look at Aboriginal controlled health centres, and we'll look at the fact that they use this and that, both traditional and contemporary wider community solutions. At the social population level, there are ways of scoring and rating and minimising risk factors and optimising protective factors at a population level. And at the individual and family level, we'll look briefly at assertive community treatment and headspace and one-stop shops, especially the concept of one-stop shops for people who are vulnerable with all these quintuple whammies.